we are a 25-year-old male who has gynecomastia chest swelling since the past 5 years. Bilateral undescended testis or absent testis according to the patient since birth and has a feminine voice.
Just stop here. What do you think is the diagnosis here?
So, sir, we have gynecomastia, we have undescended testis, so hypogonadism is there. Feminine voice. Hypogonadism is there. Feminine voice is there. That means he's not
testicular.
Pubic hair development is
there. Adrenal is there. So this is basically what. So you're dealing with a permanent hypogonadism. Whether it is a hypo or a hyper is the issue. Now gynecomastia is going more in favor of a hyper, but it can happen with hypo as we discussed. But undescended testis since birth is a big issue. So is it anorchia that will be there? How does anorchia present here?
Bilateral undescended testis and
pubic hair will be there, so this would be that sort of picture. So anyway, let's go forward.
Okay, he was 165 centimeters, so he's not very tall. There's no unicoid habitus. Bilateral gynecomastia, which is 4 centimeters, tender. And bilateral inguinal testis, 3 ml. Firm testis, pubic hair is there, and SPL 10 centimeters. So there is no micropenis. Pubic hair growth is good. And he's still prepubertal. I mean, but not 1 ml to consider as a.
So just hold on. So now, if you look at this, what are you thinking about? Could it be CDKP? It's out. Hypo.
So hypo, if it was congenital, wouldn't have caused the increase up to 3 ml. And the firm testis is also going against hypo.
Firm testis going against hypo. Gynecomastia is going against.
He has a good androgen response per se.
So he has got he's reached to a level and he's come down. This is what it looks like. So this with gynecomastia, and when you have a tender gynecomastia, what is tender gynecomastia?
It's active.
It's active. So hormonal phase is there. So this, I think, overall will go towards a stalled puberty in the setting of a hypergonadotropic hypogonadism, which is there. What was his weight?
Weight was normal. I did not mention.
So he was obese.
No, he's not obese.
He's not obese. And there is no feature of Klinefelter syndrome.
No, that's not. So
and arm span, legs length.
So actually, he had come at very that we are not checked, but he's not tall. So that's what he was not long-legged. He did not have the unicoid habitus. And no genital ambiguity.
Okay, so this is basically a hypergonadotropic hypogonadism. Now, when you talk about hypergonadotropic hypogonadism, you are probably dealing with situations in which testosterone production is defective or its action is defective. So, which of these will be more likely in this case?
So action is happening because he has a good SPL. He has pubic.
So it cannot be AIH. Yeah. It cannot be androgen insensitivity in the truest sense of the word. What else could it be?
So could it be because of the anorchia? I mean, bilateral undescended testis leading to.
So why did he develop that SPL of 10 and pubic hair of 5? So I mean,
LH latex cells are temperature resistant, so they can also form.
It is an acquired sort of a thing. So he had some development in the beginning, and now testes have come down. Yeah, carry on.
So in this individual, So the key points in this individual are that he had gynecomastia, he had a testicular volume of 3 ml, which was firm, and undescended, which is since birth.
You should rather say inguinal.
Inguinal. And pubic hair stage 5 is there. So, thinking into all this, we would think of an acquired hypergonadotropic hypogonadism rather than a congenital hypogonadism, because he's reached P5, he has a good SPL.
Yeah, so this is more like an acquired situation. Yeah.
With the inguinal since birth goes against.
And since gynecomastia is very significant, hyper will be more. Carry forward.
Okay, so SPL, that's what I said, without any prior androgen treatment, is reached SPL of 10 and without. And yes, there is no history of any sudden virilization at puberty to rule out.
So that was the other thing, whether it is a 5-alpha reductase deficiency. What happens with the testicular volume in 5-alpha reductase?
It should not be affected because it is a.
What about what will happen to testicular volume in AIF?
Not.
They will not be small.
They will not be small. That is not affected.
So because if you are having, they will become bigger. In fact, they will not be very big, but they will be at least normal size. In fact, you will have a lot of LH stimulation. If testosterone action is not there or DHT action is not there, your LH will go up. Your testes will become bigger. They will not be small. So small testes well, this means that there is they developed and then they went down. So in my eyes, the only thing which is there is probably Klinefelter will be the most likely possibility, although you may not have any other clinical features. So AI, you got the point, why AIS is out, why AIS 5 alpha is out, hypo is out. So pretty much only very limited possibilities are there.
So we want to confirm with the investigations, which showed a high LH of 18, high FSH of 32, and low testosterone of just 60 nanogram per DL. And inhibin we was done to see Sertoli cell activity, which was also less at just 14.
So this is a very simple thing. What it means is that this is, what does it mean? Can it be isolated? Can it be AIS now?
So inhibin is very good.
Yes. So
it comes.
yes. So this is a bicellular testicular failure. Both Leydig and Sertoli cells are gone. Your testo is low. Your inhibin B is low, your FSH is high. FSH is high because of inhibin B. LH is high because of testosterone. So it's a bicellular failure. So when you talk about, let's say, inefficient androgen action, you're talking about a proper global testicular defect like adrenocortical, adrenomedullary, both are gone. Same here, you've got loss of both these zones which are there. Then you talk about testosterone deficiency, which is isolated, which will be steroidogenic defects, they are gone. Because any of those steroidogenic defects, your inhibin will not be. AIS is of course gone, and your 5 alpha reductase is also gone. So this means that there is a proper testicular problem. Now, whole testis is affected, the size is also less. So next.
So can an undescended testis, wherever it might be, and push an individual into puberty?
If it is, it can work. So inguinal testis can work. So if you look at all the AIS, complete AIS, how does it present?
So they say that
they have a female, and then they become
more,
and they have got breast development. Where does the breast development come from? Testis. Testosterone is converted. So their testis is fully functional, although it is inguinal. So inguinal or femoral gonads can function. It is not that they will be bad in that sense. And as Pratik has also pointed out a very important point, that the Leydig cells are much less temperature sensitive as compared to the Sertoli cells. So your fertility will be more affected as compared to the testosterone.
So in this individual, the karyotype standard is pending. So final diagnosis would come to acquired hypogonadism.
So this will probably be a Klinefelter syndrome,
yes,
because all other causes are very unlikely. So there has to be some form of a genetic cause of a global testicular involvement. So we'll update the karyotype on that. So I think the reason we have put all these 4 cases was together because they really give you a spectrum of the entire picture, starting from CDGP to the second case, which was more of an acquired hypo, to the third case, which was more like a congenital hypo, and then the fourth case, which is basically an acquired hypergonadotrophin. So just, I think there are 3 things to look at in terms of evaluation. The first is to look at the testis, whether the testes are small, whether they are soft or hard. If you have got very small, soft testes, this is Canavan syndrome. If you have not so small, soft testes, it is CDGP, which may be improved. If you have a small and shorty testis, this is basically Klinefelter syndrome. Second is to look at pubic hair. If you have got no pubic hair development, it is either a multiple pituitary hormone deficiency or you are dealing with a possibility of a CDG. If you have got a pubic hair which are well developed, this could be acquired GnRH deficiency, congenital GnRH deficiency, or hypergonadotropic hypogonadism. If there is gynecomastia, CDGP is out. If you have gynecomastia which is mild, it could be hypo. If it is significant gynecomastia, it will be hypergonadotropic hypogonadism. Now, significant gynecomastia with shorty testis is Klinefelter. Significant gynecomastia with a normal testis is, we will not put that case, 5 alpha reductase or androgen insensitivity, because there your testis will be normal. So just if you look at these 3 things, 99% of your diagnosis will be made in that situation. So that's why we try to cover the entire delayed puberty. It's a very, very common presentation which happens in that regards. We'll see if there are any other questions there. Why undescended testis in acquired hypo?
Means Klinefelter, we are calling it as an acquired, sir, but I mean, they can have undescended testis also. This is common.
Yeah. So Klinefelter syndrome is a known cause of syndromic association of undescended testis per se, and this is not hypo. This is we're talking about hyper. So the first one was also undescended.
One-sided.
It was inguinal.